high mortality remains high, with prognosis influenced by timing of intervention, presence of other comorbidities, and the availability of specialized care. What does cardiogenic shock look like in low and middle income countries? Cardiogenic shock similarly accounts for a significant portions of those patients who develop MI, similar to what we see in the US. Furthermore, acute heart failure accounted for about 13.2% of patients who are admitted medically for all comers. And those patients that had this had an in-hospital mortality rate of 10 to 24%, and with a median length of stay of 11 to 17 days. So you can see based on this mortality and the fact that they end up staying in the hospital for a long time, it's a significant burden on the healthcare system. This is a study that looked at cardiogenic shock, particularly in Ethiopia, but I can imagine that there are a lot of similarities, with some differences to Kenya. But there are a high number of patients that present with acute heart failure and cor pulmonale, ischemic heart disease, dilated cardiomyopathy, and a significant portion of these patients, as we had previously discussed, can develop cardiogenic shock. And we're seeing some shifting trends in cardiogenic shock, not only due to acute MI, as we saw, but also heart failure related cardiogenic shock. And heart failure associated cardiogenic shock is now more common over the past decade. And this population is a little bit different because there are different baseline characteristics. They usually, because of their diagnosis of heart failure, have a higher degree of comorbidities. And they end up consuming a higher degree of resources while having worse outcomes. So we'll talk about some core update areas for clinical guidance in cardiogenic shock. We'll discuss early identification and evaluation, the importance of having a multidisciplinary team, hemodynamic monitoring, pharmacologic therapy. We'll touch briefly on temporary mechanical circulatory support and talk about how the ICU team can really work together in the context of the multidisciplinary team to help outcomes in these patients. So early identification and evaluation. So I think it goes without saying that timely recognition of any shock state is critical into improving outcomes. And early intervention can help reduce morbidity and mortality. Traditionally, criteria that looked at treating cardiogenic shock or identifying cardiogenic shock, excuse me, focused on looking for hypotension and organ hyperperfusion and low cardiac output states. But, there's been a newer phenotype of cardiogenic shock that has emerged as a potential high source of mortality, and that's those patients who develop normotensive cardiogenic shock. And then the setting of this, when they don't have a concurrent hypotension, we have to develop more nuanced diagnostic tools that can help really identify the full spectrum of patients who have cardiogenic shock. And one of the tools that has been developed to help aid in early identification and evaluation is the Suspect CS. And it's a diagnostic mnemonic that serves as a structured tool to confirm early diagnosis. And you can see here that it goes by the Suspect CS name. So first looking for symptoms and signs of altered perfusion, such as altered mental status, confusion, chest pain, low blood pressure, signs of congestion as well, such as elevated GVP, crackles, rales, orthopnea, and lower extremity edema. Urine output, looking for end organ manifestations of the kidney with oliguria or anuria. Sustained hypotension, a systolic less than 90 or a MAP less than 65 that sustains over a time period. So one blood pressure point alone, it is inadequate to help rule in the diagnosis of cardiogenic shock. And then using some additional lab values to help confirm that there is hypoperfusion present. So a lactic acid that's elevated, signs of congestion of the liver or the kidneys, elevated ALT, elevated creatinine, And then also an ABG where you can use your pH, your bicarb to confirm that there's evidence of tissue hypoxia and acidemia. EKG and echocardiogram, obviously, when you're evaluating a patient with cardiogenic shock, can be very helpful to help you rule in or rule out acute MI or heart failure as a potential etiology. Evidence of congestion, which goes into a lot of the symptoms and signs that we talked about, and then triage to help triage them to the appropriate team. And this helps you really start with the suspicion and then confirming with the elements of the mnemonic in a way that all the elements of all the parts of the team that can understand. So point of care ultrasonography can really serve as a helpful tool when further a consultative cardiac ultrasound may not be relatively available. And we're certainly seeing a rise in point of care echocardiography to be used as an early surrogate to help identify those at highest risk. And what you're looking for here is signs of early LV/RV dysfunction, regional wall motion abnormalities, as well as acute valvulopathies that may suggest that this patient may be at risk for having cardiogenic shock or have already developed sequelae of it. So here you can see an example of a point-of-care ultrasound, a parasternal long axis view. And in this view, you can appreciate that there's significant biventricular dysfunction. I don't know if you can see my pointer here. The RV does not seem to be contracting. The LV myocardium is not squeezing in very well. In fact, there's really no change in that LV cavity much between diastole and systole. And then you can also see here this trace pericardial effusion, which really it's present, but it doesn't really tell you much about the etiology of shock in this patient. It's most likely the myocardial dysfunction. And it's important to know that in this mnemonic and for early identification and evaluation, invasive hemodynamics are not really required. I mean, they can be helpful to tailor management to help define which ventricle is involved, assess the congested profile, or guide treatment decisions, especially when complex. But really relying on your history, your physical exam, understanding the comorbidities, and using the point of care ultrasound when you can help you avoid doing more invasive hemodynamics, which haven't really been shown in all populations to lead to early diagnosis or stratification in management. So when we talked about classification of cardiogenic shock, this is kind of the classic rubric that I was certainly taught in medical school. You're looking for not only evidence of adequate perfusion, are they warm or are they cold? And then looking at whether they're congested, are they dry or are they wet? And classic cardiogenic shock, you can see in the lower right-hand corner, usually was cold and wet. They had low cardiac output as a result of congestion from poor myocardial contraction, which led to an elevation in their pulmonary capillary wedge pressure, as well as an increase in their SVR or SVRI. But a lot of these elements of this diagram really require the invasive hemodynamics to help further classify. After you classify the severity of diagnosis, really there's been a more movement to understand the severity of the shock stage. It helps provide a standardized framework and helps support decision making and importantly triage. Where does this patient have to go? Does this patient require ICU monitoring? And here you can see the SCI or SCI staging for cardiogenic shock that was really introduced in the late 2010s to help provide a common framework for understanding patients at risk or if they had fully developed cardiogenic shock. So you can see here the SCI staging is stratified into 5 different categories, A through E. A is those patients who are at risk. They're not currently experiencing any signs or symptoms of shock, but they're certainly at risk for this. These are your patients who have heart failure potentially, who have had an MI, who currently have adequate forward flow and systemic perfusion, but you got to keep an eye on them. B is when they start to developing signs of inadequate perfusion, usually manifesting with relative hypotension or tachycardia, but still without tissue hypoxia. C is when they develop this classic cardiogenic shock picture, when they develop, the low systolic blood pressure, and that usually requires intervention. And these patients typically require some kind of medical intervention to provide adequate support. And then when you get beyond C, that's when you really have to be thinking, what further interventions do I have to do for these patients? Those that are deteriorating or doomed, they may have failure that has failed to respond to the initial interventions. And those patients at extremis are those patients who've actually already fully experienced a level of cardiovascular collapse. So they're having refractory cardiac arrest. They're undergoing active CPR, and those are those patients that, without a very invasive strategy, are very at high risk of declining. And you can see here, this is a further framework that helps delineate how a patient could easily move from a shock stage A to B to C to D to E, depending on the severity of their shock, and helps you classify them by looking at elements of their physical exam, such as their JVP, are they warm or well perfused, looking at their pulses, their mentation, their lung sounds, and then also including biomarkers that we had discussed before that look at signs or symptoms that really pinpoint signs of end organ hypoperfusion, such as your lactate, LFTs, renal function, GFR, as well as your BNP. And then using your hemodynamics. So blood pressure and MAP obviously goes without saying. And then if you have further invasive hemodynamics, such as your Swan GANs, PA-SAT, CBP, to help delineate where they are in this shock stage. So why use this shock stage? Well, it helps really track the progression of cardiogenic shock. It helps standardize communication between care teams, and it helps guide potential escalation of therapy so that everybody is on the same page about where this patient is, where they're at risk of going, and what kind of interventions may be necessary to prevent further escalation in the severity of their shock. Next, we'll talk about multidisciplinary team care. We talked about how it's great to have a common language to help define patients. And the common language is helpful because it gets all the elements of a very different team at times to understand the acuity and the complexity of a patient. The other thing that one of the things that has been shown to be helpful is having a multidisciplinary team to take care of the patient. So having an an ICU team, having a general cardiologist or heart failure cardiologist, and then also potentially even more advanced cardiology, such as heart failure, heart transplant cardiologists, those that have more experience in advanced therapies to help guide which patients may be suitable for which kinds of level of support. However, there is a lack of outcome data on interhospital transfers, highlighting that there is still a critical evidence gap in cardiogenic systems of care. Um, Having said that, multidisciplinary team care is associated with overall lower in-hospital mortality, and this is from multi-center analyses because these team-based systems that have experience in working together to take care of these cardiogenic shock patients, they have not only the ready ability to manage patients with invasive hemodynamics, but they understand the rubric at which they need to advance to further levels of potentially invasive care, such as advanced temporary mechanical circulatory support. And as a result of understanding the potential natural history of these patients, there's less risk-adjusted ICU mortality. And the core team members can vary a lot by institution, but can include members of critical care, cardiology, advanced heart failure. Here in our unit, we also have cardiac surgery, and then palliative care, which is ultimately an outcome that has to be considered in a very high-risk patient population. And this multidisciplinary team care can work together for patient selection, understanding and discussing cardiogenic shock features, employing systems of care, and then also deploying different therapies. Importantly, on our into the multidisciplinary team, we also have pharmacists that help us understand the medications that the patients are on and what they potentially may need to be on, and understanding the different roles that these the goal-directed medical therapy that can be helpful. Because if you can, we try to employ these medications rather than more invasive measures because mechanical circulatory support, as we'll talk about, is an incredibly expensive endeavor. It's resource intensive, and it's very risky. And if we can avoid it, by all means, we definitely try to. Invasive hemodynamics, I am very biased. I came from an institution that employed the Swan-Ganz catheter a lot. I am at an institution that loves using the Swan-Ganz. And it can be helpful to characterize the cardiogenic shock phenotype, help you assess shock severity because you're able to get indices such as your index, your wedge pressure, and able to track whether the medical interventions you're doing over time have actually been effective. It can help you guide either escalation or weaning of therapy. And observational data suggests that there may be a benefit despite a lack of benefit that was really demonstrated in two very powerful randomized controls trials. The ESCAPE trial looked at cardiogenic shock patients, the use of the PA catheter in cardiogenic shock patients, and decompensated heart failure as well. And it didn't really show that there was any benefit. For those of you that practice in the ICU, you're also familiar with the Pac-Man trial, which used the Swan-Ganz to help guide therapy in septic shock patients. And again, it didn't show any benefit and also it demonstrated a potential signal for harm because the use of these invasive hemodynamic tools requires practitioners who are familiar with them who can do them safely. But there are some registry and claims data suggesting that improved outcomes can come with pulmonary catheter use, and I think we're seeing more of this. The PAX trial, which is currently ongoing, is testing the hypothesis of whether early PA catheter can improve heart failure outcomes in patients that present with decompensated heart failure. So I think right now, there's still an element of equipoise, but I think in those centers that have a lot of familiarity using them, employing them early may have a benefit in being able to risk stratify patients appropriately. So different kinds of hemodynamic profiles in cardiogenic shock. There is an observational data link between RV and biventricular congestion to higher mortality and an increased need for advanced failure therapies. So I think this may be familiar to a lot of you, but when you're looking at LV dominant failure, you're thinking about an LV capillary wedge pressure that's elevated or an LV end diastolic pressure that's elevated. RV dominant is when the evidence of LV congestion is not present, insofar as your wedge is normal, your left ventricular and diastolic pressure is normal. You may not necessarily have a lot of congestion on your chest X-ray, but you've got a really elevated right atrial pressure. And biventricular is when you really have both present, and this is the highest mortality group. And these patients are particularly challenging to treat because the employment of advanced therapies can be really challenging in this group. Pharmacologic therapy, like I mentioned, is always usually our first line treatment, and the primary goals of therapy are really to relieve congestion, optimize cardiac output, and restore perfusion to vital organs. Management of congestion, I think this is familiar to all of us from, our first year of med school, really, but it's important to optimize preload, and I always find that challenging when I'm teaching my residents and fellows. Well, what does optimized preload mean in the setting of RV or even LV biventricular failure? It's trying to find the right place on the Starling curve where you're not causing so much distension that you're not able to provide forward flow, but you still have adequate preload so that you can provide forward flow. And that can sometimes be a tricky balance to weigh. But I would say for the most part, patients who present in cardiogenic shock, be it from heart failure or ACS, they usually come in with a need for diuretic therapy. And our first line is IV loop diuretics. And then we're pretty early to use adjuncts such as thiazides or even early renal replacement therapy, depending on their sky staging to help relieve the congestion. And really what we're looking and monitoring is their transrenal perfusion pressure, their MAP minus their CBP to ensure that we can provide adequate flow to their kidneys. Management of hyperperfusion and cardiogenic shock, we use vasopressor therapy titrated to support our perfusion. You want to minimize the duration and the dose due to the adverse effects from having one dose of too high a dose of one medication, because this can lead to arrhythmias and increased myocardial oxygen demand. And I mean, we're all familiar with the different level of medications that we can use for managing systemic